And then I'll turn it over to Rosemary then right away, or is that who's going to start? Okay,
yes.
Very great.
Yes.
All right. So everyone, let's just start with some housekeeping. I know we all have Zoom fatigue and we are zoomed out, but just as a reminder, we will have time for Q&A at the end of today's amazing session. If you would like to ask a question of our panelists here, please use the button at the bottom of the screen that says Q&A. Do not use the chat function. You can use the chat function to kind of talk with one another or talk with me or June or somebody. But if you have a question for our panelists, please use that Q&A button. That's what we'll be monitoring at the end to send questions to our panelists. So those are the housekeeping rules. And so now I'll just start by welcoming everyone. Happy New Year. Yay, 2021 is finally here. We are so excited to welcome you back to our FSHD University educational webinar series. Again, we're so looking forward to keeping the learning going this year, to give you, our families, the arsenal of knowledge so you can be your own best advocate when it comes to your care. So that's what FSHDU is all about. Today, from our research department, we welcome Rosemary Shull and Lisa Hugo of AMRA Medical and Michelle Melian from Fulcrum Therapeutics. We all know Michelle very well, but AMRA is the Swedish company that's working with Fulcrum. They're working with Fulcrum Therapeutics in the Redux 4 clinical trials, and they're going to explain how MRI works and the role that it's playing with Fulcrum's Redux 4 clinical trial. So, June, would you like to properly introduce our panelists?
Yes, I'd be delighted to. And I also want to say that FSHD University, in addition to empowering you to live your fullest and best life, is empowering you to understand research, kind of peek under the covers a bit, because there's a lot that's happening. And we believe that the more you understand how these things work, the better you can be, both as an advocate for research, but also to have realistic expectations of where this will all go. That's really important, because we have tremendous hope, but drug development is not a magical process. It's a very difficult, demanding process with a lot of intersecting parts, a lot of science, a lot of uncertainty. But as I said, we live in a great time of hope. So we hope that our educational programs will give you the right balance between a realistic expectation of what's going to happen and how you can, best partner with the research community to accelerate these efforts. So MRI is a powerful technology for non-invasively seeing inside the body. And for example, to be able to see how muscles are affected in individuals with muscle diseases. And it's currently one of the promising tools that's being investigated to see if it can track disease activity in FSHD. And today we have the opportunity to learn how this technology works and is being used in an FSHD clinical trial. Our presenter today is Rosemary Shull, who is Senior Vice President of Global Business Development and Marketing for AMRA Medical, which is working with Fulcrum Therapeutics. She's an experienced leader in business development, sales and marketing in medical imaging, software, drug development, medical devices, oncology, musculoskeletal and metabolic diseases. And she's a former high school teacher and currently certified yoga instructor. So she's going to be the perfect combination of having the knowledge and the teaching skills for FSHD University. Following her talk, she'll be joined by Dr. Michelle Melian from Fulcrum Therapeutics, and they'll be happy to answer your questions. So without further ado, Rosemary, it's all yours.
Thanks so much, June. Thanks for that great introduction. As June said, my name is Rosemary Shull, and it is such an honor to be speaking with each one of you today. As she said, I'm the lead for business development and marketing at AMRA Medical. We are a Sweden-based company in medical imaging. We work in the areas of medical device imaging as well as imaging for clinical research studies. And as she mentioned, we work with Fulcrum, and I'm super excited to have Michelle Melian, Dr. Michelle Melian here standing in as backup, and she'll be here to answer questions during the Q&A session. So during my talk today, I will first give you a semi-technical overview of MRI. Then a description of the individual experience in the MRI scanner. And third, a bit about what AMRA measures from a whole body MRI scan. I have a couple of disclaimers. I'm not a scientist, I'm not technically trained, and I'm not a doctor. I'm just a person who was a teacher, as June mentioned, for many years, and I've spent the last 18 years working in the field of MRI for clinical research. So I'm going to share in layman's terms what an MRI means and what your experience may be like. And then disclaimer number 2, many of you may have had much more experience than I in an MRI scanner, although I have been scanned many times. You may understand the mechanics much more technically than I do, and I respect that completely. So, if I get boring, you can just scroll on your phone a little bit and then come back when I sound interesting again. So today, I'm here to share enough information with you to ideally, A, make you feel more comfortable about having an MRI, B, give you some insights into the technology, and C, give you enough information to make you dangerous the next time you go to talk to your doctor. No offense to any doctors on the call today. I'm sure you agree that a well-informed individual is an ally indeed. And here's the MRI overview. So what is magnetic resonance imaging? Basically, you're taking a giant magnet, radio waves, and a computer, pulling them together to take very detailed pictures of the inside of your body. And here's the lower body. You can see my cursor, I believe. And then here is a knee image. And then this is an axial image through the abdomen. And you can see the arms on the right and the left. And I'm going to come back to that, the different planes that you can be imaged in. And what scanners are available. The most common field strength magnets for human imaging is a 1.5 Tesla and a 3 Tesla. AMRA works primarily with GE, Siemens, and Philips, the big 3, but there are many other manufacturers of MRI scanners around the world. There are over 30 to 50,000 units available globally and tens of millions of scans performed annually. So back in the day, when I was trying to understand what this giant magnet was all about, this is what I found. And it made a lot of sense to me. So I'm sharing it with you today. A 1.5 Tesla magnet can lift a car in a junkyard. And in most neuromuscular disorder studies, a 3 Tesla magnet is used. So double the field strength. So 2 cars in a junkyard lifted by a magnet. Although it's much more technical than that. With the magnet strength information that I just shared, it should help to understand why you cannot wear jewelry or have any other metal in the scanner room. You'll see, and again, many of you have probably already seen it, but there's a line in the doorway that no metal can cross. There's lots of equipment inside the room. Looks like it's metal, but it's actually not. In my experience, I've heard about situations where a cleaning bucket, a walker, a desk chair, something metal has been pulled literally into the magnet and gets stuck. So it's a very dangerous situation. So this is an important precaution. This type of accident then requires that the magnet has to be powered down, the metal object removed, and then the magnet has to be powered up again. The entire process takes about 2 weeks. So it's dangerous and it's extremely time consuming. And that leads to scans not being able to happen during that period. And then I'll get more into the patient experience, but I wanted, as we talked about the magnet, I wanted to share that. So why have an MRI? Why would you want to have one? Why use one? MRI is known as the gold standard in soft tissue imaging due to its excellent soft tissue contrast. An MRI, coupled with functional tests that I'm sure you're familiar with, like a 6-minute walk test, a stair climb, time to up and go, reachable workspace, for examples, provides a much more detailed look into what's happening within the muscles that are part of that functional test. In addition, the literature now shows that MRI changes precede functional changes and therefore may be predictive of response to therapy before the functional tests show any changes. I'll talk later about the friendliness of this modality, which is another great feature of MRI, but I wanted to share this information with you first. MRI has been around for quite some time. It's entering its 5th decade of clinical use and has come a long way since Sir Peter Mansfield, pictured here on the left, created the MRI scanner, including improved personal comfort, as you can see on the right. This is where I get this. This is the semi-technical part. On an atomic level, the body consists primarily of hydrogen, oxygen, and carbon. On the molecular level, these atoms primarily form water, fats, proteins, and minerals. On the molecular level, about 60% of the body weight can be attributed to water. The magnet and the radio waves together are able to excite and relax the water molecules in the body. Different tissues give off different signals during the scan due to their water properties, so they show up differently on the scan. Therefore, you can see clear delineations between fat and muscles in the tissues. And companies like AMRA can quantitate the amount of fat or muscle fat infiltration in muscles being followed in a study. And just to back up just a second there, you can see in the center, the hydrogen atoms, they're spin, and they are excited and relaxed by the combination of the magnet and the RF, the radio frequency. And then it produces a lovely MRI image. So why use MRI? Well, again, MRI is known as the gold standard for soft tissue imaging due to its excellent soft tissue contrast. MRI is also very versatile as an imaging device, making it possible to see many things in the body. Here we see an MRI image of the entire body. The tissue contrast is great, and this is a perfect base for measuring muscles. And then on the left, you see some brain images, which may look familiar to you as well. This next slide, I'm going to play the video a couple of times. What I'm going to show to you is a coronal image, which is looking at the body from front to back. And I'll just move on and show you. So on the left, you're seeing an axial view that is cut through the body. In the middle is coronal, and on the right is sagittal. The sagittal is going from one side of the body to the other, coronal from front to back, and the axial is coming either from the head down or from the feet up. And I want to play that for you one more time. So I don't think people usually get to see this level of detail of what you're getting from your MRI scan. And then when you try to look at when you look at a smaller body part and you take these three different views, you're getting a 3D image, and you're getting a tremendous amount of information out of the MRI scan. And I think we're also used to just seeing a two-dimensional flat image, but it's much more than that. AMRA sets up multiple MRI scanners, often globally, at the start of a study. We train the MRI technologist on how to obtain the exact scan for what is to be measured in a study. There are many variables in setting up an MRI protocol based on the scanner itself and what is to be measured or observed. In essence, MRI is a lot like life. There are a lot of trade-offs, but this is not challenging when you understand the field of MRI, and the image itself produces so much information about an individual's body. And now into the individual experience. Scanners used for an FSHD MRI protocol are open-ended machines, meaning both ends are open, so air can flow through. Most scanners have an integrated fan, music, and ambient lighting. Many even have a TV. Listening to an audiobook or watching a favorite TV show during the scan can make all the difference to an anxious participant. A typical appointment for the whole body protocol is around 60 minutes. This includes time for patient preparation, an opportunity to ask questions, coaching, and safety screening. In all, there is a total scan time of about 40 minutes. So the hour scheduled allows for time to get settled, have your questions answered, not rush anything during the scan time. It's enough time for you to close your eyes, relax, and potentially meditate if you like. You really can relax in the scanner if you take deep breaths. I recommend deep breaths. This picture shows a typical scan room environment. Again, the scanner is open at both ends, and also it does not move or rotate. Instead, the bed moves in and out of the scanner. The bore, meaning the center part, is typically between 60 to 70 centimeters wide. There's no cumbersome equipment involved in the body scan. The participant is escorted into the scanner and positioned so that you are lying comfortably on a flat bed cushioned beneath you. Blankets are provided as needed, and once in the scanner, the participant should feel unrestricted with the fan air moving around you. I will also add here that the technologists I have met over the years are very kind and concerned about your comfort during the scan. They want you to feel good, they want you to feel relaxed, and they want to be able to capture the best data possible during the scan. Coils may be used during your scan. They are lightweight and generally unobtrusive. This particular coil that you see in front of you collects the signal from the anterior part of the anatomy, which is then converted into a digital image, and this one is used for liver scanning. There is a buzzer and an intercom used to enable two-way communication with the staff during the examination. The scan is noisy, I'm not gonna lie, it's noisy. It is typically around 110 decibels, about the same as a concert. Earplugs protect your ears from the noise. The MRI machine makes noise only while the machine is obtaining an image. Within an MRI scanner, there are large coiled wires called gradients that are used to create the magnetic field. During a scan, an electrical current runs through the coils, causing them to expand and make a loud clicking noise. It might be a good idea, if you've never had an MRI, to play the sound from YouTube or some other media before the scan to start to get used to it. And then when the scanner is going over parts of your body where they're not impacted by your breathing, I'm going to come back to that. I'm ahead of myself. But it's important to note that it will be noisy, but it's not noisy all the time. You will be asked during some of the scanner time to perform breath hold scans. These breath holds are under 20 seconds long. The participant is coached prior to the scan about a breath hold. You'll be asked to hold your breath via the intercom while the images are being acquired. This enables the images to look sharp and without blurring, much like avoiding movement when you're taking a photograph, as you see in the race car on the left, and then it's blurry on the right due to motion. And then the MR image here is crystal clear, and on the right you see motion artifact. So that's the reason you're asked to hold your breath, so that you get a good crisp scan that is really good for diagnostic purposes, as well as for the purpose of doing quantitative imaging and measurements from the scan. The MRI protocol, meaning exactly what the scanner itself needs to do, is pre-programmed into the machine. Therefore, there's no manual interaction required from the technologist except to begin scanning. This leaves the operator's attention focused purely on the participant. As each scan is concluded, the operator checks the images for motion to ensure that the participant has complied with the breath hold instructions. If any images are subject to degradation, they'll be repeated. The scan is painless and does not require an injection of a contrast agent. Performing breath holds keeps the participant in direct contact with the staff. This interaction reduces the levels of claustrophobia and anxiety in people who are apprehensive. The MRI scan is a relatively short, interactive, personalized experience with an excellent positive patient experience rate. And I look forward to your questions on this during the Q&A session. This last part is about processing the image data for measurements. At AMRA, we acquired the images, the examples that you see on the left. The data is sent to our lab where we perform the measurements required by the study protocol. We then send back the results to the sponsor of the study. For example, the sending results to Fulcrum in the form of an Excel file. This data can then be used to make decisions on the effect of a particular new drug. AMRA uses our own proprietary software to perform automated segmentation of the tissues in the images. This segmentation technique makes the measurements reproducible, since manual segmentation introduces more variability. At AMRA, we are using an automated atlas-based image segmentation method supported by artificial intelligence. And I'm going to get into a little bit of the detail here in terms of looking at fat and lean tissue in a scan. What you see here is an axial image looking up through the thighs, and a muscle area has been identified by the algorithm and then checked by a human being. The red area is lean muscle tissue. The yellow is fatty tissue. And then here, we're able to segment out just the lean, fat-free muscle tissue. And here, we're able to look at and quantitate reliably, reproducibly, the fatty tissue. And then you're able to calculate from there muscle fat fraction. All of this information within the muscles throughout the body gives the treating physician, researchers, and pharmaceutical companies a tremendous amount of information to make care decisions for people living with FSHD and other neuromuscular disorders. This last piece is an example of segmented muscles in an individual. You're looking at the whole body scan. Specific muscles have been sectioned out, segmented out. And then the image turns and you see the axial view going up through the body with the identified muscles. And that is what we're able to track over time in response to therapy. In closing, I am profoundly grateful to anyone on this call who has volunteered to be in a clinical trial. Your contribution to humanity is immeasurable. I wish each of you good health, and if you find yourself in need of an MRI, I hope this presentation helps you to feel less anxious, better informed, and ready to take on the world. Thank you.
Thank you so much, Rosemary. I think that's the first time I've heard a talk. Sorry, I've got to put my camera back on. I've heard a talk that really goes into what it's like from the volunteer, research volunteers' perspective, and I think that's so important. So we are open for questions, and I see some questions coming in. Michelle, welcome also to this Q&A portion. First question, is the ratio of fat to lean muscle, is that an indication of how affected a muscle is? Is that kind of an objective measure of how affected a muscle is?
I'll leave that one for Dr. Melian.
Yeah, so first of all, I have to say, Rosemary, this was a fantastic talk, really, really great, fantastic information. And I think that, as you said in your talk, looking at one of the measurements called a muscle fat fraction is one of the ways that we measure muscle health from these MRIs. And it's really important that we looked at several different types of measurements of muscle health with the MRI. And you also mentioned them in your talk as well, Rosemary, that being the muscle fat fraction, which looks at how much fat is in a muscle, the lean muscle volume, which looks at how much muscle or viable muscle there is, as well as the muscle fat infiltration, which looks at how much fat is actually in that muscle, which is viable, so to speak. And so by looking at all of these parameters, we can get a good idea of muscle health, overall muscle health, not only from the individual level, but up through regional levels and through the whole body.
Great, thank you. We have a question. Someone wants to know, how is an MRI different from a CAT scan?
So a CAT scan, I'll start and then I'll turn it over to Michelle if you've got something to add. A CAT scan gives you, so if you're comparing them side by side, a CAT scan gives you better bone segmentation, better views of bone. An MRI gives you better soft tissue information, but you do also get soft tissue from a CAT scan. but a CAT scan has ionizing radiation, and there's no radiation in an MRI. A CAT scan can be much quicker than an MRI, but the detail that you get from an MRI is far better in the soft tissue area.
Great. And I'll just, for those who may not be familiar with the term ionizing radiation, that is usually like an X-ray type of very high energy form of light that can actually damage cells. So we try to minimize our exposure, for example, to X-rays because it can damage your DNA and so on. And so what we're saying is CAT involves that type of radiation. Actually, I think it's in the form of positrons, but anyway, and MRI does not involve that type of radiation. So there's a question, what is the cost of a whole body MRI scan? And maybe one thing to go into there is when you showed those like those sections, let's say the axial section from the toe to the head of the body, how many slices are you making, as it were?
So in terms of the cost, it varies widely throughout the world, and it depends on who the payer is, whether it's a insurance company, if it's an individual paying. There's a wide variety. I've seen in research studies where an MRI is $500 per hour. I've seen where an MRI is $2,000 and above for that particular scan. So the cost varies widely. And then you went into how many slices are in the body, and I don't have a good answer for that. A lot. I can come back to you with that, and maybe June, you could disseminate that information, unless Michelle knows.
I don't know off the top of my head, but I can tell you that each slice is approximately can be different thickness, and so the number of slices that you get depends on the thickness. So depending on whether you're doing 1 millimeter slices versus 3 millimeter slices, that would certainly impact the number of slices you get. So it depends on how you're scanning the body and what you're interested in, and then also about the thickness of that slice.
Yeah. And related to that, there was a term you used in your talk, segmentation. And I thought perhaps some listeners may not be familiar with that. Can you explain what segmentation is and why it's such a costly thing?
So this image should help. Do you see my cursor?
Yes.
Okay. So here on the left, the blue is the subcutaneous fat and the pink is the visceral fat. So with using AMRA's algorithms, the algorithm is able to identify all of those fat and muscle tissues, the fat tissues that you see on the left, and then the muscle tissues that you see on the right. So it segments out the different tissues specifically. This is fat, this is muscle, etc. Yeah.
And it has to do that for each slice that goes through, right? So then you can connect.
Yeah. If we were to go all the way back to the video of the 3 planes, that's the whole body scan, and the I passed it, sorry. It's like it doesn't want to go to that slide anymore. No, it's going. So this is putting all the slices together here in the image. I'm not sure why it's not playing. Probably because I want it to.
Okay.
Sorry about that. Yeah. So that is all the slices put together that you see in the axial plane, the coronal plane, and the sagittal plane. They're basically stitched together, which you can see in this image. It started to play. So these regions of the body are put together. Each slice comes together in order to do the quantitations.
Right. And each slice shows many, many things going on, bone, parts of the bone, different cross sections of muscle and fat. So it's a tremendous amount of stuff, slice by slice, that somebody has to figure out where the outlines are, and then you have to combine them all together. So it's a tremendous amount of data. I wanted, I'm just mentioning that because I wanted people to, they see the end result and it looks magical, but there's a huge amount of computation and
there sure
work
is
behind it.
And these are example of just a slice here. So that's a coronal slice. This is an axial slice. And then the algorithm drops the boundaries on the different tissues throughout the entire scan. And then a human goes in and just reviews the boundaries that the algorithm has applied and makes sure that they're correct. And then from there, the quantitation is done automatically.
Great. Thank you. Here's a question from someone who is asking about 7 Tesla MRI. And would there be an advantage to using it for this type of research?
And that's a really good question. It's not very common to use 7 Tesla. It has its own limitations. It's not widely available. I don't know a lot more about it than that. Michelle, do you have anything on 7 Tesla?
No, you're absolutely right, Rosemary. I mean, 7 Tesla is typically used for research protocols. And again, it's not widely available. And but we do get excellent images with the 3 Tesla magnets and have really great protocols and sequences with which we can get fantastic information.
Right. I believe, drawing on what I can remember from my physics, I think to get that powerful a magnetic field that's uniform enough, it's really challenging to create a bore that's big enough for a human to fit into. So we've seen them used for like mice and rats, but someone can correct me if I'm completely off base on that. But we have someone wondering, I don't know if, Rosemary, this is just out of the blue and you may not have an image right at hand, but they were curious to know how an MRI between a healthy person and one with FSHD would compare if you were to look at say a particular muscle region that's affected in FSHD.
It's a really good question. Let me see if I can pull up one of these other images from earlier. So this is a good example, looking at the muscle and the fat within a given muscle region that has been segmented out here in this image. If a person were, a triathlete, somebody who is training all the time, you're not going to see fat within the muscle. They may still have some other fat. They may have subcutaneous fat, et cetera, but they won't have that muscle fat infiltration. And the more fat you see, the less healthy the muscle is. And Michelle, I should turn that over to you as the MD to provide anything else.
No, you're absolutely right. So what you would actually see here is that there would be no fat in the muscles that you're looking at here. And again, Rosemary, as you pointed out, in this muscle, you can see that there is a significant amount of fat in this muscle, and so this could potentially be a more diseased muscle, whereas you would not expect to see that amount of fat in the muscle.
Great, thank you so much. We have a question from someone asking if they were to have an MRI. I think right now this kind of MRI would be mostly done in a research study. I don't think you would normally get it as a part of a regular doctor visit. But they were wondering if a patient would receive the report letting them know which muscle groups are most impacted. Michelle, would you know that?
So, so whole body MRIs are available, not necessarily the AMRA protocol widely. This protocol that is being used in the Redux 4 trial is specifically for research use. But there are clinical protocols where you can look at the whole body and evaluate, not necessarily as I think that the clinical protocols are not as optimized as the AMRA protocols, but you can certainly get an idea of which muscles are severely affected and which muscles are not affected with the current clinical protocols that are available clinically. And however, as somebody else had pointed out, to obtain an MRI, a physician would have to order it for you, and you would have to go through the appropriate channels of organizing to get that MRI.
Great, thank you. Well, we're talking about clinical use. Actually, this can be for research as well. Someone was wondering if they have any metal dental work or metal plates, say from fixing a broken bone or something. Would that interfere with the MRI?
That's a really good question, and it's going to depend on the type of metal. In terms of like, I don't want to be quoted on this because I'm not the doctor here, but the metal implants in your mouth are fine, and I believe most metal implants in the body, including somebody who's had a hip replaced, they can still have an MRI. The problem there, though, is that there's tremendous artifact that comes like a spray of light that comes from the metal in the body, which makes the images a lot harder to read. Michelle, do you want to expand on that?
Sure. So before you go and have an MRI, you undergo what's called a screening questionnaire. Each institution may have different screening questionnaires to make sure that you don't have the type of metal in your body that can potentially affect or be dangerous for you to have an MRI. We would certainly, for example, if somebody has had a gunshot wound, certainly they would not have an MRI because it would be there would be heating up of the metal related to the MRI, and that could certainly damage tissue. And so we want to first and foremost make sure that you're safe to have the MRI, and then it really depends on what the reason for the MRI is. So, for example, if you have a hip replacement, but we're looking at your head, it's not necessarily going to affect the images. However, if you have a hip replacement and it's the type of metal that can go into an MRI, usually titanium is okay. Then you can get the MRI. However, as Rosemary said, sometimes the images are not usable because that metal may create what's called, as Rosemary said, an artifact, which looks like slashes of white across the image. And sometimes it can make those images very hard to interpret.
Great, thank you. So I think going back to the use of this MRI in the context of research like what Fulcrum is doing, there's a question: how is the standard of muscle determined? Like, do you have a benchmark of here's a healthy muscle versus the FSHD affected muscle? And even among normal people, muscles vary a great deal. So how do you determine, what your benchmark is?
That's a great question, June. For the Redux 4 protocol, we required patients or subjects to have at least one muscle that was called to be STIR positive, and to have a certain fat fraction, meaning that muscle had to have a fat fraction between 10 and 40%. The reason being was that we were looking at those particular muscles because those muscles were ones that have been shown in other data to most likely express DUX4. And so we did have that inclusion criteria for the Redux 4 clinical trial. However, we do know, as we're looking at the clinical trial, what we're looking at in the Redux 4 clinical trial is progression. So we're looking at 18 muscles, 36 in total, and looking at how they progress on those measures of muscle health, that being the muscle fat fraction, the muscle fat infiltration, and the lean muscle volume, and seeing how their progression is affected. We do know from studies that for the most part, muscles that have more than approximately 10% fat in them are usually not healthy muscles. But to your point, June, you're absolutely right. As we get older, unfortunately, our muscles become more fatty. So hence is the reason why it's really important to follow people along a timeline, or for, for anywhere from 24, or in the case of the REDUX4 clinical trial, we followed people for 44 weeks. So we're really looking at that data in a longitudinal sense and trying to understand how the muscles changed in that approximate 1 year period.
Well, relating to that, we have a question from Mike who says, is MRI the best way to measure treatment effectiveness in a trial?
That's for Michelle.
That's for Michelle, yes.
Rosemary actually covered this point beautifully in her talk, I think, and so in FSHD and in many muscular dystrophies, it's very hard to measure progression on our clinical outcome assessments, because these outcome assessments are not very sensitive. And so in order for us to see changes in these outcome assessments, we have to follow people for a long period of time, sometimes 5 years, sometimes 10 years. And that is really prohibitive. Obviously, we want to find effective treatments more quickly so that we can get them to patients and patients can be helped as quickly as possible. And so MRI could be a great way of detecting these changes sooner, prior to when we might see these changes on these clinical outcome assessments. And so it's not that the clinical outcomes are not important, they are very important, but this can be an earlier signal as to the efficacy of a treatment, so that we don't necessarily have to wait to see the impact on those clinical outcome assessments, but we can actually see the impact in a picture. So for example, when I'm going to take muscle fat fraction, we know that muscle fat fraction increases over time in subjects or patients with FSHD, and we have an idea of how of the cadence of that progression. And if we can slow that progression, we know that those muscles stay healthier, and that could potentially correlate, or does correlate, with how well you do on a clinical outcome assessment. And this has also not only been shown in FSHD, but in other muscular dystrophies, such as Duchenne muscular dystrophy, where a lot of this work has been done showing these correlations with muscle fat fraction and with how people or how patients with muscular dystrophies perform on these clinical outcome assessments.
Great, thank you. I think some people may wonder, like, hey, if you can see what's going on in the muscle, isn't that the best measure? Why do you need these functional assessments?
Right. Well, we also want to make sure that people are benefiting from the treatment that they're getting, so that these changes that we're seeing in muscle and that we're preserving muscle is translating to a clinical benefit. And that's not only for clinical outcome assessments that we have, like the TUG or the timed up and go for those that are not familiar, or the 6-minute walk test, but it's also in the way that you all feel. So the reason why we give patients questionnaires is because we also want to make sure that it's helping them in other ways. So again, that's also a very sensitive measure for us to tell whether a treatment is helping you. And so answering those assessments are extremely important, and answering them truthfully is extremely important.
Great, thank you. So I think it's easy for patients to kind of get confused, because there's so many different parts to a clinical trial. They hear that you're measuring DUX4, they hear you're doing MRI. So here's someone who was wondering if MRI can itself identify the presence or the activity of DUX4 gene.
So actually, this has been looked at by the Wellstone group, and what the Wellstone group did find was that when you have when you have a brightness on one of these protocols, something called a STIR protocol, when you have brightness in a muscle, that muscle is more likely to express DUX4. However, we don't necessarily have a measure to evaluate for the amount of DUX4 that's being expressed. We can say that it's most likely to be expressing DUX4, but we don't necessarily understand the amount of DUX4 that will be expressed in that muscle. And so that is something that we're trying to understand further with our colleagues at AMRA and us and them helping us to interpret these MRIs, as well as marrying that up with what we're learning about the DUX4 endpoint. So both are important to our understanding of the disease, as well as understanding the potential impact of the treatment on the disease itself. And then again, really understanding the totality of the data, looking not only at DUX4, looking at the muscles, the muscle health. And in this case, we're very lucky that AMRA has this technology, because we're able to look at whole body muscle health, not just lower extremities, which in many cases is what's been done in the past. And that this advancement is really an incredible advancement for us to be able to look on a whole body basis at muscle health, and then also understand the clinical benefit, not only on the clinical outcome assessments, but also on the patient-reported outcomes.
Mm-hmm. So it's a lot of connecting dots of things that are they truly correlated, or are they just coincidental? For example, again, going back to the physics of the MRI and what Rosemary mentioned at the very beginning, is the MRI is actually measuring the amount of water in the tissue. So it's not measuring the DUX4 gene, because it doesn't have the physics to detect or identify the chemistry unique to the DUX4 gene, but it can detect the increased presence of water, which we interpret as inflammation, which we think is connected with DUX4 gene activation. So it's not a direct connection between what you see on the MRI and the presence of DUX4. You have to infer that, but then you have to prove it, that there's actually a correlation. That's why you do muscle biopsies. Is that correct?
That's right, June. That's right. And similarly to what the Wellstone group had seen with their study, was also corroborated in our preparatory study, where we also took biopsies from patients such as those on the line. And thank you very much. If any of you have participated in that study, we couldn't have done it without you, where we were able to identify those muscles that have that higher STIR signal, and we were able to detect the DUX4 signature in those muscles.
Okay. We have questions. Oh, go ahead.
I'm sorry, June. Could I add quickly to that? We're not necessarily measuring the water. We use the water, the hydrogen atoms to excite them and relax them in order to get a different signal from the different tissues, which show up as a different grayscale, a different color in the image. Measuring edema, measuring water in the tissues is a bit of a holy grail, that it's a bit of a problem that is not really completely solved yet. So we are really measuring fat and lean tissue.
Mm-hmm. Okay.
Just to clarify.
Thank you. Yes. A question here, as a patient, she says, I was told that affected abdominal muscles in FSHD have become thin and elastic rather than fatty. Have you analyzed what the abdominal muscles look like in your studies? And can you comment on that? That might be for Michelle.
I think that's
okay. Yeah, no, that's okay. So capturing and again, this goes back to Rosemary's a talk where she was talking about the ability to clearly evaluate muscles that are especially that are located especially in your thorax or your body core. And so it can be very difficult because there's a lot of movement that occurs there, and because these muscles are so affected, it can be very difficult to get those measurements. And hence we were unable, we're looking, we will continue to look at the information that we get from those images and hopefully be able to report back to you when the study is complete on what we learn.
Thank you. Here's a question asking whether the reduction of fat fraction has been observed in any of the MRI studies of FSHD patients over time. So not necessarily just the Fulcrum studies, but other studies that you're aware of.
So to my knowledge, MRI has not been used in any other treatment study for FSHD. However, there have been several natural history studies that have looked at the progression of muscle fat fraction, not necessarily using the AMRA method. The AMRA method is slightly different, and the images are acquired in a different way than other MRIs. But in looking at those other natural history studies in which a treatment was not applied, there was an increase in muscle fat fraction over a 1-year period.
I seem to recall there was a Dutch study a longitudinal study where some patients showed a reduction of fat fraction in some muscles.
Yeah, some increase, some decrease, and it goes to the heterogeneity of the disease and which muscles are affected, which is another aspect of FSHD that we don't necessarily understand is why are some muscles more affected than others in this disease.
Right. Here's a question. In a severely affected FSHD patients, what is the highest fat fraction found? So to what extent can that fatty infiltration occur in a most severely affected muscle?
Right. So I've seen muscles that have been completely fat replaced, unfortunately, in FSHD.
Right. Let's see. There's so many questions I'm scanning through here. Here's something just from someone who apparently might have participated in an MRI study. He said, my facility that performs my MRI must have an older piece of equipment. There was no TV or music. Is it possible to have music piped into the room? Or Rosemary, what do you?
That's a really good question. I would definitely inquire ahead of time because, again, I know those technologists are very keenly focused on patient comfort and the patient, being okay, the participant being okay during that scan. So I would be calling ahead of time to say, what can you do to make me more comfortable, as well as potentially providing some type of headphones that can send in music that are compatible with the MR scanner.
Yeah. There's a patient who would like to know, can she still participate or volunteer for MRI studies?
I'll leave that to Michelle.
Sure, absolutely. I think that the best way to learn about ongoing clinical trials and clinical trials that you may qualify for is through the FSHD Society. Certainly June and her team keep up to date on all clinical trials that are ongoing in the FSHD space. If you're interested in other MRI studies, another great place to go and another great resource is clinicaltrials.gov, and you can put in your search criteria and find out information from that website about what trials are ongoing, whether they're in your area, and they also provide contact information as well as if you're interested in learning more about participation.
Yeah. So I'm not aware of any ongoing studies that are still recruiting for an MRIs, but there's great interest in using MRI and to further validate them as a way of tracking disease progression and so on. And so I would, with reasonable confidence, predict that there will be more studies in the near future. So just keep your ears open. We'll certainly let you know about any that we know about in our newsletter, and clinicaltrials.gov. You know, if you visit it every few months to search, I would recommend that. So there are some questions pertaining to the clinical use of MRI. Again, we touched on it before, but again, if we can reiterate, are there circumstances under which a doctor would prescribe an MRI for an FSHD patient?
So I think that there are other ways that people may need an MRI, and it would really depend on the medical issue that that person was having. Certainly, if they had, I noticed that somebody had chatted in earlier that they were having some neck pain, and there was concern that there could be a problem in their neck, and so they had an MRI of their neck. And so there are other reasons why FSHD patients would need MRIs, and certainly an MRI should be thought about if it's appropriate for whatever that complaint may be.
Okay. Here's a question also in the chat. What muscles did you find were affected the most in the upper legs?
So in the upper legs, and I think that this is consistent across the literature, the hamstrings tend to be the most affected muscles, whereas those tend to be the most earliest replaced muscles with fat.
Okay. Did those studies indicate what is a typical time progression for the deterioration of those hamstring muscles?
Not to my knowledge, June. You know, as you all know much better than I do, this disease has different time progression for, you know, even within families, and so it's very difficult to predict from the time of diagnosis when or how long it will take for a muscle to deteriorate, unfortunately. And sometimes the deterioration seems to happen very, very quickly, and sometimes it seems to happen slowly. It seems that I've talked with patients who have said, I have these relapses, if you will, almost like where they have time periods where things seem to be progressing very quickly and then plateau. And then some people just kind of go along, and unfortunately there's nothing that we have found or that I know of currently that predicts what a patient's progression is going to look like.
Here's another clinically related question. Do you know if neurologists are trained to evaluate the MRI data from a patient, and is it ever used, for example, to evaluate which muscles are healthy in order to inform, let's say, the prescription of an exercise therapy?
Yes. So I think that it's really helpful to know and to be sure that we understand what's causing a patient's weakness. Certainly, if there are other complaints, if you had neck pain or pain shooting down your arm, and then your arm became weak, I would want to know, is the reason why the arm is weak, is it related to the neck pain, or is it related to disease progression in FSHD? And that could certainly help inform whether it seems that the disease is progressing or whether there's something else going on and that we need to intervene on to make sure that there is not progression of the disease or contribution to weakness related to progression of FSHD. And so I think that in terms of determining what kind of exercise, I think that I myself do not use MRI to prescribe exercise. I think that it's really important to work with the physical therapist and to understand what exercises are appropriate. Exercise has been shown to help preserve strength in patients with FSHD. So I would highly recommend talking with your physical therapist, understanding what exercises are appropriate, and then following through and doing those recommended exercises.
Great, thank you. Here's a question asking about little buttons that were used during I think it's during the Fulcrum study, that were attached to the legs. What were those for?
So those little stickers are called fiducials, and these fiducials help to mark specific muscles that we were evaluating. So these fiducial markers, they kind of look like little donuts, and we stuck them on particular muscles that we were interested in evaluating, because those were muscles that we were thinking of to biopsy. But these fiducials are also critical markers for us to tell the biopsying physician where that STIR positive muscle, or that area of STIR, that high signal, was located. So it was a marker not only of the muscles that we were interested in, but it's also a marker, and it helps to orient that physician that's doing that biopsy to where they should be orienting the needle. And you can actually see these fiducial markers on the MRI scan. I believe that they're filled with like a gel-like substance, right, Rosemary? That shows up on the MRI scan as like a little P, so that you can see where you need to go.
Great, thank you. We're just about out of time. We have one last question. Is the Fulcrum trial okay with the delays created by the COVID-19 pandemic?
That is a fantastic question, and I have to say that going through this pandemic with the FSHD community has been humbling. The amount of commitment from the FSHD community to this clinical trial has been incredible. And for us here at Fulcrum, we couldn't be more grateful to those patients that have participated and have really stuck with us through the pandemic. We at Fulcrum tried to be very proactive with how we reacted to the pandemic by altering our clinical trial in order to preserve our endpoints, so that we can deliver high quality data and get enough data to answer the important questions we're asking in this clinical trial. And as part of that, as most of you know, the clinical trial was initially supposed to be 24 weeks, but because of the pandemic, we extended it to 48 weeks. To give every patient enough time so that we can collect all the biopsies, all of the MRIs, all of the clinical outcome assessments that are needed to give us the data in order to inform our assessment of the efficacy of losmapimod to treat FSHD. So I have to say that, you know, without this community and this community's commitment, we could not have done it without you. So for those of you that are out there, the families that have supported us through this and have remained in the trial, I can't thank you enough. And we are really looking forward to sharing the data with you later this year, and to continuing to working with our AMRA colleagues to provide answers to these important questions we're asking.
Thank you so much. I'm going to bring back Beth Johnston now for some final concluding remarks, but thank you so much, Rosemary, and thank you, Michelle.
Thank you.
Yes, my brain is definitely full. Thank you. And thank you everyone for attending our FSHD University webinar today. Very, very special thank you to Rosemary, Michelle, Lisa, for taking the time to be with us today, as always, and for the amazing information and for answering all of our kabazillion questions. So thank you guys very much. Our next monthly FSHDU webinar is on Thursday, February 18th at a regular time of 1 p.m. Eastern. Our topic's going to be early onset FSHD, and our guest speaker will be Dr. Tina Duong from Stanford University. These webinars are scheduled for the third Thursday of every month from 1 to 2 p.m. Eastern. Next Tuesday, January 26th at 8 p.m. Eastern is our Caregiver Sharegiver Hour, specifically for those who are providing care to loved ones with FSHD. And our monthly Wellness Hour is Monday, February 8th at 5 p.m. Eastern. The topic at our Wellness Hour on February 8th will be pain management, but these sessions are really open to all topics related to our well-being. Our radio show featuring Tim Hollenbach is the second Tuesday of every month at 9 p.m. Eastern. And next month on February 9th, Tim's guest is going to be Sue Drescher, who co-hosts the Caregiver Sharegiver Hour. So, but the radio show is now live streaming over YouTube rather than on Facebook. So be sure to follow our YouTube channel so you can receive alerts about these live stream events and other updates to the channel. As always, check our website events calendar for all upcoming events, including local chapter meetings. Watch your email inbox. We send updates once or twice a month. And again, thank you very much for joining us today, and we will see you next time. Bye-bye.
Thank you.